Disclaimer. This video content is AI generated as educational purposes only and is not a substitute for professional medical advice, diagnosis or treatment. Your health concerns may be unique. Always consult your physician or a qualified healthcare provider for personalized guidance.
Today, we are diving into the brand new 2025 guidelines for managing anemia in chronic kidney disease. These new recommendations are a real game changer for one of CKD's most exhausting complications, so let's get right into it. But let's kick things off with a question that really gets to the heart of the matter. If you or someone you know has kidney disease, you might be all too familiar with this feeling, a deep, persistent exhaustion that's way beyond just being tired. So where does that come from? Well, very often the answer is anemia. And this is not some rare side effect. The problem is absolutely massive. In some places, like India, a staggering 50% of all patients with chronic kidney disease are dealing with anemia. That's a huge burden, not just for patients, but for the entire healthcare system. So what even is anemia? Well, to put it simply, it's when you don't have enough healthy red blood cells. Think of these cells like a giant fleet of delivery trucks carrying oxygen all over your body. If you don't have enough trucks on the road, your body's tissues get starved of the oxygen they desperately need to function. And that is what leads directly to that bone-deep fatigue and a host of other serious issues. So here's our game plan for breaking down these new guidelines. First, we'll look at why anemia happens in CKD in the first place. Then we'll build our pyramid of care, starting with the foundation, iron. After that, the balancing act of modern treatments, a few special cases, and finally, what this all means for a whole new era of care. All right, first up, why does kidney disease cause anemia? Well, your healthy kidneys are kind of like factory managers. They produce this really important hormone called EPO, which is the signal that tells your bone marrow to start making red blood cells. But in chronic kidney disease, the kidneys are damaged, so they can't send out enough EPO signals, and that whole production line just grinds to a halt. And as you can see here, it's not just one problem. The main issue, for sure, is that lack of EPO, but it's a perfect storm. You can also have an iron deficiency, which means the factory has no raw materials. Chronic inflammation can jam up the machinery. And to top it all off, the few red blood cells that do get made often don't last as long, so you're fighting a battle on multiple fronts. And because this is so incredibly common, the guidelines really stress proactive screening. Just look at how the frequency ramps up as the disease gets worse, from once a year in the early stages to every 3 months and all the way to monthly for patients on dialysis. The whole point is to catch it early, before it puts a huge strain on the heart. This brings us to the most important part of our pyramid, the foundation of all treatment. Before you even think about other medications, the 2025 guidelines are crystal clear. You have to start with iron. Full stop. So the diagnostic path is really logical. Step 1, you do that regular screening to see if there's even a problem. Step 2, you gotta play detective for a minute and rule out other things. It might not be the kidneys, right? And then step 3, and this is crucial, you have to assess the patient's iron stores using a couple of key blood tests. Now, this is where it gets a little nuanced, but this visual explains it perfectly. On one hand, you've got absolute iron deficiency. Think of it like an empty warehouse. The iron's just not there. But on the other hand, you have functional deficiency. This is trickier. The warehouse is actually full of iron, but inflammation has basically locked all the doors, so the body can't get to it. Those blood tests we just mentioned, they're the key that tells doctors which problem they're solving. Is the warehouse empty, or are the doors just locked? So the single most important takeaway here is this. You have to fix the iron problem first. It doesn't matter how many signals the factory manager is sending if the factory has no raw materials to build with. This quote from the guidelines really says it all. It is the essential first step. Okay, once the iron stores are sorted out, then we can move up to the next level of the pyramid, modern medications. But this is a very delicate balancing act. The goal isn't just to raise hemoglobin, it's to get it to a very specific, very safe level. And this chart illustrates that target range perfectly. If your hemoglobin is below 10, you're probably going to feel those awful symptoms of anemia. But, and this is so important, we learned the hard way from past research that pushing it too high, say above 13, is actually dangerous. It can make the blood thicker and increase the risk of stroke. So, that sweet spot right there between 10 and 11.5 is the goal. You improve quality of life without adding unnecessary danger. So, to hit that sweet spot, we've got two main tools. For decades, the standard has been injectable drugs called ESAs. They're basically synthetic versions of that EPO hormone. But the really big news now is a whole new class of oral pills called HIF-PPIs. These are super clever. Instead of injecting an external hormone, these pills trick the body into thinking oxygen levels are low, which naturally convinces it to ramp up its own EPO production. It's a more natural approach, and let's be honest, the convenience of a daily pill versus an injection is a massive game changer for so many people. Okay, we've made it to the top of our pyramid. This is where we talk about specific patient groups and the one tool that we only use when it's absolutely positively necessary.
Treatment is not one size fits all. For kids, the guidelines often suggest IV iron just to cut down on all the pills they have to take. For folks with a kidney transplant, you have to monitor things much more closely. And for patients who have both heart and kidney issues, we now know that another class of drugs called SGLT2 inhibitors can actually give a nice little helpful boost to hemoglobin levels.
So, what about blood transfusions? Well, they are truly a last resort. We're talking about using them in emergencies only, like after major blood loss or before a big surgery. For just routine, long-term management, they're avoided. And that's because they carry their own risks, like infection, iron overload, and even making a future kidney transplant harder to get. And that brings us to our final section. When you put all of these pieces together, the iron first rule, that careful balancing act with new drugs, and these tailored approaches, what does this new era of care actually look like for patients? The main theme here is a major shift in how we think about this. We're moving away from a rigid approach that just chases a number on a lab report. Now the focus is on a strategy that is safer, much more convenient thanks to those oral therapies, and highly personalized to every single patient's needs and risks. And the impact of this is very real. The analysis shows that by using these updated, more careful strategies, we could see a potential drop in major cardiovascular events, we're talking heart attacks and strokes, by a really significant 15 to 20% in this population. That's huge.
So we'll end with this thought. The ultimate goal of these new guidelines is pretty profound. It's to transform anemia from this debilitating, defining feature of kidney disease into something that's just a manageable condition. It's about giving patients back their energy, giving them back their quality of life, and finding a much safer path forward.
Hi there, forest friend. Thanks for clicking on our video. We're so happy you're here. Before we jump in, don't forget to like, subscribe, and share this video with your friends.